Good morning, Kansas City. We're back to talk coronavirus again this morning with our special guests. On my right is Dana Hawkinson, our Medical Director of Infectious Disease. Again, I like to refer him to as Dr. Hawkeye or Dr. Hawk. And on my left is Dave Lisbon, who is one of our outstanding emergency room physicians here at KU. I've known Dave Lisbon for a very long time, all the way back to when he was an intern and I was trying to talk him into internal medicine. Somehow,
that's true.
It is true. Somehow he made a U-turn, backward turn, left turn, went over a couple of railroad tracks, up and down the mountains, and ended up in the emergency room. I'm not quite sure how all that happened, but Dave and I go a long way back. And I think he'll be able to answer some really great questions about the emerging data around racial disparity and coronavirus, as well as some concerns about people with domestic violence and what that has, how that's gone in the age of COVID-19. As we go into our question session, I do want to remind you all that it's really important to stay home. I know that this is the second night of Passover. Easter approaches this weekend, and all of those are causes for folks to come together. Remember that the rate of infection out there in our county is probably somewhere around 5 or 10% of all people having coronavirus, maybe more, maybe less. But think about that. If you go into a gathering of 50 people, it means that 5 probably may well have coronavirus. They may well be asymptomatic. And we know that that's how the disease spreads. So you use good judgment. We can't, we can't substitute medical judgment for, your personal judgment and the things that are important to individuals and to people. But what we can say is that we know how to bend the curve because we're seeing it happen all over the world. And it is to shelter at home, stay more than 6 feet apart. If you're going to go out in public, wear a mask. Make sure that you cough into your elbow, wash your hands, don't touch your face. And we know that that works because, Dana, it's working nationally and internationally.
Yeah.
How are we doing here at KU this morning?
Today at KU, University of Kansas Health System and Hospital, we have 33 patients total. We have 20 who we're ruling out for infection. 9 of those patients are in the ICU, but a majority of them are on the normal medical floors, so that's very good.
Yeah, we're doing. Those are reasonable numbers at this point, I think, in this crisis. Mm-hmm. Dave Lisbon, talk to us a little bit about what you guys are seeing in the emergency room and things that you know are important issues here in our area.
Yes. So I think that it's very interesting for me. This actually marks about the 1 month period since, so to speak, this jumped off. I was in a meeting in New York, March 9th, came back to Kansas City. And
he was not sick when he came back.
I was not.
We had to check.
I was at a medical meeting, actually, and also visited family because that's where I'm from, and really got back to find that the health system in my department was gearing up for how we would respond to this really new novel kind of threat and challenge. And it's very interesting. Emergency medicine kind of thrives on sometimes acting with incomplete information, continuing
I would never say that.
continuing to develop hypotheses about what a disease is and what it does and who's at risk. So we were actually, we felt pretty comfortable with that kind of scenario as it relates to kind of how we act in general. We're always kind of risk stratifying and trying to decide who is at most risk. So, in a very short order, we were able to decide how we might partition the emergency department to keep individuals who might be infected from having an issue with the whole ER, routing those patients who were less ill and those who are more ill, and then working in concert with our ICU specialists as well as our internal medicine docs to decide who needed to be admitted. And so that was the big bang start of last month, and I really have been pretty impressed by the collaboration between the emergency department, the other services in the hospital, and of course our critical care community when we really needed to work quickly and work safely to take care of the patients who are most affected.
Yeah, I think we stood up. How many bed is that? The kind of the COVID treatment area. How many beds are
Right.
there?
So
12
there's
beds?
about 8 to 9 beds there. That was a pretty fantastic effort of actually, for our audience, we actually transformed our ambulance bay into an area where we could actually evaluate patients who were suspected of possibly having COVID. And that became the area where we would decide if those people needed to be admitted or went home. And we even developed another area where patients who were more obviously ill, so maybe respiratory problems that were outright. We had our thoughts on people with underlying illnesses, diabetes, hypertension, unstable vital signs, and put them in another about 7-8 bed area where we could work on them intensively and put a staff in place that would always be back there, so decreasing the back and forth of our faculty and staff.
Not have to worry so much about all the protective equipment,
Exactly.
good infection control, and
Yes.
those things. So,
Yes.
yeah, good. Do you think your team feels safe there?
I think they do. I really think they do. I think they've been heartened by the response to the health system in terms of getting us the protective equipment we need, in terms of getting us resources to ramp up how we can best help when patients are really critically ill. So this is a situation where aerosolization is the word we use, can happen. So intubation, procedures that expose us to blood and body fluids. And it's just been amazing to watch the ICU, your colleague, Dr. Keano, some of the anesthesia staff and some of our ER staff and residents actually developing real elaborate devices to help us safely do the most life-saving procedures. And it's just been a pleasure to watch. I mean, I think, we work with a great group of people.
We are blessed.
Yeah,
We really
I
are.
agree with that sentiment.
So there may be questions out there. We're happy to try and answer what we can, and if we can't, why we'll tell you that. What's going on?
Good morning, everyone. Good morning. This is Taylor at Channel 41. I was asking because you guys are starting your calls every morning with kind of an update on the numbers there at the hospital. We're starting our newscast every morning with an update on local numbers. And I don't mean this to be a challenging question, but what is the value in tracking those numbers right now and keeping and putting those out to the public? What is there value in that? Is at this point, are we way off potentially with the number of people that may be out there that have it, that we don't have confirmed testing? What's the value in keeping track of those numbers and reporting them on a daily basis?
You bet. That's a very fair question. Dana, your thoughts?
Yeah, I mean, I think locally, and I think Dr. Lisman can speak to this too, he knows some updated information. I think it's important for transparency and to allow the general public to understand what we are seeing and dealing with every day here at the hospital. But then I think on the broad spectrum as well, just the overall numbers, because we know that the overall numbers here are much different than they are in New York. We don't ever want to get to New York. And so it's also helping, hopefully, to reinforce our message of staying home and staying safe. And I don't know if either one of you have anything to add to that, Dr. Lisman?
I think that knowledge, or rather data, is always important, and I think the health system's done a good job of giving us updates. Just looking at our metro area as it relates to Johnson County, say, versus Wyandotte County, and looking at the numbers of positive individuals who've been tested. So we get a sense of how perhaps the disease is moving among different communities, different cohorts. And I think it highlights sometimes what we know about health disparities. COVID is actually unmasking a lot of the health disparities and health inequities that exist. Dr. Stites was just sharing with me, as I've been following the data, that somebody has done a study with about 14 states and are already showing that African Americans and others of color seem to disproportionately be bearing the brunt of both the infectivity rate and, unfortunately, the fatality rate.
I'm going to take one different angle to that question, which is this. We don't have great testing data in the United States. We don't, right? So how do we measure the spread of the disease and where we are on any potential curve so that we can try and plan for what could come? And the answer to that is we really only have one other estimate, which is how many people are hospitalized and how many people are on ventilators. That's really what's telling us where we are in the curve, because we haven't tested enough people out in the community, because we don't have the same public health structure we once did. We don't have the same kind of testing we once had, and the ability to do those things. So without that ability to really assess the public's health, we're left with trying to take care of what it's like when you become acutely ill, and the acute patients are in the hospital, which means our data lags 10 to 14 days behind where the community is in infection, because it takes about 10 days to get sick enough to be hospitalized in general. And so because those statements are true, then what you have is a number of patients who are hospitalized or on ventilators representing what's going on throughout the public. So to me, that's knowing what hospital data is, because it gives you a sense of where we would be on any curve. And here's what we know. We've been at the same number now for about 4 or 5 days, 6 days, something like that. And we actually have a few less ventilators than we had a week ago. And if you look at that, you say, oh gosh, we flattened the curve. Well, that could be true, or it could be true that we're just on that slow rise portion of the curve. We'll know more about that ultimate answer in another 1 to 2 weeks. As I said yesterday, we are haltingly, cautiously, very guardedly, imperfectly optimistic that we have begun to flatten that curve. But it's way early to make that statement. We're hoping it's really true, but it's way early to make that statement. And that if we have done that, and there's a good chance that there is some flattening of it, if we have done that, it's because people took the shelter at home, the 6 feet away, and all those other things very seriously, because the core 4 area, our metropolitan area, did a really good job of closing public places like schools and bars and restaurants, and that has come at a great economic impact to our area. I'm not trying to minimize that at all, but purely from a healthcare perspective, I think that has, I think we're going to, that made a real difference.
And I would
This
like.
is Angie with KCTV5. I'm talking about knowing numbers and knowing data and it being important. Do you guys feel like it's also important to know demographics and to know about race? Because Jackson County is now saying they don't want to release specific numbers on race. What are your thoughts? Is that important for them?
Well, I'm going to give you a healthcare answer, not a political answer, because I don't want to get into the political space.
Fair enough.
Yeah, but I think in the healthcare environment, yeah, it makes an. It's really important, because what it really tells us, Dave, is that people who have not as much money and live in more crowded conditions without as much health care, they don't do so well with this.
Absolutely. It reminds me of a statement I read or heard, or it's a saying. It's like, we're all in the same storm, but not in the same boat. And
that's pretty good.
I think what's interesting about this is that we use race data in a lot of other studies, and one would think that and many people are calling on our Health and Human Services commissioner to make that data available. There is evidence out of Louisiana that even though African Americans make up perhaps in those areas like 25% of the population, they are bearing about 70% of the fatality rate. And that is obviously disproportionate. So the questions are, what's at play in that? Certainly there's intersectionality that has to do with income, that has to do with education, that has to do with long-standing health care inequities, but we won't know more about them if we don't collect that data. So I agree with you. I don't see why we wouldn't get that data.
Dana, thoughts?
Yeah, I think overall for the general health and public health, certainly that is helpful. We think we know, and hopefully our case fatality rate, that means the number of diagnosed cases to deaths, is much lower than other countries, but we still don't know the infection fatality rate. So that goes back to the general statistics questions. We need to know how many infections overall are out there, what demographics are infected the most. Hopefully when we do get more information, more data, more statistics, we'll see that our case fatality rate here in the United States is much lower than other places, and that the overall infection fatality rate from this infection is much lower than initially thought as well.
In the
Follow
study
up on that. Is it important for your patients to know that information, or do you feel comfortable that if doctors know it, that would be enough?
So I think I'm going to try to answer that just from a health system, public health perspective. Look, there's a study that came out, I think it was yesterday, of 100,000, no, I don't remember, the number was published.
140,000?
Yeah, I don't remember the number now, but I think they actually looked at 1,400 or 1,500 patients in 14 states, and they tried to say, what did it look like? Who was affected the most? And what they found is that in terms of 1,400 patients, about 33% of the people who are hospitalized were African American. Well, that is really disproportionately high. So if we're going to try and do a strategy to prevent the spread of the disease, how much sense does it make to ignore hotspots, right? How much sense does that make? Well, the only way to really do this, we clearly need to get into different communities and understand why that's a hotspot. Now, I think to Dr. Lisbon's point, you sort of know, but that's a presumption, and that's different than real knowledge. The only way you can know that is to get in and study it, and the only way you can study it is to have the information that shows you where to go. And so I think from a health perspective, absolutely. And then you'd go you talk to communities that are particularly affected. It would be like saying, well, we're not going to go look at, we're going to ignore the data about nursing homes. Well, would that make any sense? Ignore the data about nursing homes, because otherwise you wouldn't do interventions aimed at trying to help prevent the disease spread amongst people who are a vulnerable population. So the answer is the only way you can beat disease is with knowledge. Otherwise, we'd be ignoring the entire pandemic, and I suspect that would be a mistake.
And I think to your point, we want to empower, we have been doing this to empower the people with knowledge. We continue to say very simple messages so it can permeate through the community. We can tell our leaders, our public health professionals and leaders can tell our political leaders, but really the main people that are going to change it in whichever community, in any certain community, are the people living in that community. And so it does boil down to individual responsibility.
And I want to, if I could just say, one of the thoughts about health in the public health space is social determinants of health. Tell us a little bit about how and why and when people can access various modalities that might help their health, right? So we've talked about, are you underinsured, not insured? Does your employment situation dictate that you pretty much must come to work and be further exposed? I think those are real things that have to be looked at and considered and dealt with when we talk about people's ability to adhere to everything. For instance, I grew up in Brooklyn, New York, apartment complex. Sheltering in place and social distancing, you might almost say, was a bit of a luxury. I couldn't have done it very easily if I wanted to. We were a family of six apartments on one floor, 13-floor building, and New York is a hugely dense place, so that's a difference than what we're experiencing here in Kansas City. But just be mindful that not everyone can actually do, especially folks who are marginalized and have less access, all of our best recommendations. So that's an issue at times.
Well said. Next question.
Hi, this is Nate with the Health System. If someone gets COVID-19, do they develop an immunity?
Yeah.
Okay, Dana,
Yeah.
What do we know?
This is a great question. This is one of the most common questions. The best evidence we have right now is what we're doing in the midst of everything. Prior to that, it was the original SARS infection. We know that people can mount antibody response and build antibodies, and that will infer protection. It's unclear exactly how long that protection or those antibodies will last. We know it lasts at least up to 2 years, and after about 2 to 3 years, they really start to wane, the antibodies. So we don't know that. We hope, and I think the general thinking is that for the near future, say 3 months, 6 months, maybe a year, you would hope to have immunity. But we still don't know the answer to that question. So that is one of the good studies that we are trying to do, and I think that everybody is trying to do. I know that there are healthcare workers who are going back to work now, going back to treat COVID patients. So that's a very good question. We are still trying to learn, will you have immunity, which hopefully you will, and if so, for how long and how much, so that if you're re-exposed to the infection, you will either get very mild symptoms or no symptoms at all.
Other questions?
I do have another one. Oh, sorry.
Go ahead, Angie.
You go first.
Just a question about, we're seeing some people leaving their medical gloves on the ground, masks. They go to a store and then they just throw them on the ground. What are your guys' thoughts on that? And what do people need to know if they're trying to protect themselves and wearing those items out?
Yeah, first I'm just going to say, and then I'll turn to data. God, so I am a Trekkie. I apologize for that. To Dana, Dr. Hawkinson.
I'm not Dana.
Yeah, that's right. You do have data.
I do have data.
You have data, but I just want to say about putting your mask and gloves on the ground, what a really bad idea, right? What a idea.
Right.
Making somebody else pick that up.
Yeah, I think littering in general is not a good thing. You know, take your gloves off correctly. You can just put them in your car, on the floorboard, wherever, and then throw them away when you get home. I think that's just, hopefully, you know, just a general principle of, you know, not good society
Not a good
measures.
behavior.
Just
Yeah.
don't litter.
Right, it's kind of like everything you learned in kindergarten once
Yeah.
again, so yeah, please don't do that. And there are the right ways to take on and off your gloves and your mask. We have videos posted on our website if you have any questions about how to do that. But it's all about the D&D, donning and doffing, and how to put things on and how not to, and how to take things off. And when you go to take them off, just take them around around a wastebasket.
Yeah.
You know, so I was out in Loose Park today, kind of doing an early morning walk, and sure enough, there were gloves and masks laying on the ground. I'm like, really? There's a trash barrel 50 yards away. How hard was it to go over there? So, you know, just be socially responsible and make sure that your germs don't become somebody else's germs. Put them into that trash and don't make somebody else do that.
And you know, I'd like to say that can't be echoed enough. I mean, I think what people have to really think about is we live in community. Steve said something early on in his, communicating with the health system and the public, which was that, you know, this will affect somebody you know. And I've actually known 2 people who actually passed away from COVID and one who got it and recovered. And so Steve said, this is going to affect somebody you know. And so that's already happened to me. So I think just being mindful that, you know, every move you make at this time can impact somebody, and if it's not for the better, boy, why would you do that to somebody?
Yeah, because we are all in it together.
Yeah,
Right? We
yeah.
are all in this together. Okay, I think we are clear on that answer.
No litter.
Yeah, no litter. Next question. And
Yeah, this is Nate again.
please.
Do you think the testing that's going to be starting in Johnson County will help our data and show us, I guess that would give us a better idea where we're at?
Dana?
What is the new testing?
I'm not sure. I can tell you some of it. I know.
Because I heard a little bit about it too.
Yeah, and we're ramping up here as well, and the county health departments are ramping up. The KDHE has got more testing ability. I absolutely think it's going to make a really important difference, and it's not only going to make a difference of where we are today, but as we pass through the surge, whatever that surge looks like, and the disease starts to tail a little bit, COVID is still going to be out there until we have a vaccine or a cure, or until it mutates and goes away. And even then, you got to be a little suspicious. So if it's still out there, and we're going to, you know, there are already discussions nationally, and you can hear the echoes locally. This is of such great economic harm that we understand people are going to need to reopen businesses and try and get back out and do things at some point. When you do that, you have to couple that with really good testing, because you have to be able to detect every micro hotspot wherever it is, so you can practice good infection control. And in fact, in tomorrow's show, Senator Jerry Moran, will be on the show with us to talk about the economic health of our country and our state and our area. So really important, just to kind of segue to that, but also to say that testing will be a pivotal, bad word, of whatever we're going to do when it comes to reopening the economy and our society, because you have to be able to track who's got the disease, what the contacts are, and that has to be readily available testing to manage that. We're going to live in a post-COVID world. When I mean post-COVID, it will still be there. It'll be post the surge. That means we're going to have to accept a little bit of risk, because COVID's still going to be out there, and we have to manage that risk. And the same principles about hand washing and trying not to be in huge public gatherings are going to be true for a while. And that means you're going to have really good testing to allow you to detect who and where has the disease, get to those contacts, and try and do things to help intervene. And I can't stress that. I think it's a really important development. And it's also true nationally. The testing is becoming much more available finally. Does that answer your question?
Hopefully.
Okay.
That wasn't exactly mine. That was one that was.
The listeners, you bet. Another
Yeah,
question.
but, I mean, that was a great answer.
Well, I don't know if it's a great answer or not. I think it's right.
Whatever the question was,
Yeah,
it was a
whatever.
great
That's
answer.
right. We always give great answers. That's our plan.
The questions aren't.
Yeah. Next question out there. Anything from one of our reporters or anybody else?
I have one more from Facebook if you're willing to take it.
Go for it.
Somebody is saying that there are videos that going around on social, not from medical professionals, touting the benefits of quinine and zinc, seemingly without any clinical trial evidence. Can you please speak to this?
Yeah, well, let's speak to that, and let's speak to some of the things having seen people try in the emergency room, and we'll also go back to address hydroxychloroquine for a minute. So, Dana, lead off. Quinine, zinc, what do you think?
Yeah, again, I think it was stated there's no compelling evidence that any of this stuff works to, number one, prevent symptoms or prevent disease or actually treat it. It's important to note that there are a lot of things on social media. I would be very careful about where you're getting your information from and your sources. I would really stick to your either local health department, state health department, or the CDC websites, or even the World Health Organization website for better guidance on that stuff. I don't know that necessarily taking a little bit of zinc every day is going to harm you. But certainly for the quinine or hydroxychloroquine, again, the evidence is just not there. We do have evidence of side effects from those things, especially like hydroxychloroquine. But in general, for those other things, especially posted on social media, I would be very reluctant to believe any of that.
Dave, in my practice, I know I get people coming up with all sorts of interesting ideas all the time. What do you see in the ED?
You know, so far with COVID, I have not seen at least people touting any kind of remedy from social media or otherwise per se. Matter of fact, I've been actually pretty impressed that a few individuals who had tested positive had seen their primary care physician, and that person hadn't started them on anything that hadn't been thought out and approved, and they were being sent here for further evaluation. So I think from a community perspective, that's very good. I think people are hopefully holding their heads to I guess, as my wife say, if Fauci doesn't say it, it's not good. And I laud Dr. Fauci. I think he's been a great bellwether through this.
Yeah, I think it's the season, right? And Passover has a lot of meanings in the Judeo-Christian faiths. And I would just say that when it comes to COVID, the best thing you can do is let it pass over you. And the way you do that is to shelter in place, stay 6 feet away, wash your hands, don't touch your face, cough into your elbow, and try and stay healthy the best you can. Not sure if those other things are really going to impact this disease. The things that matter most are the simple things you can do. Question.
I have one more question. Yeah,
Please.
And this is for Dr. Lisbon, please. I'm wondering what you're seeing in the emergency department as far as sexual assault and domestic violence. I know that's been a concern
That's
for
a great question.
a lot of people.
Yes, that is a concern. What's interesting about this COVID pandemic, if you will, is in our environment, has actually led to a decrease in overall volume. I mean, our emergency department used to pump through 190, 200 patients a day in January, and we've watched those numbers drop a great deal, sometimes as much as 50%. So a couple of days ago, I think we saw 109 patients, for instance. So, I think what our public and our populace should know is that, we stand ready to continue business as usual. If you have a concern, or if you're a person who is a victim of domestic violence, our SANE program is up and running full tilt. We will continue to be able to address your concerns and treat you with compassion and dignity the same way we did pre-COVID. And I think that's something that all members of the public should keep in mind. We are, in fact, the safety net. If you've got a medical concern of any kind, we stand ready to flex up to deal with COVID, but to continue our great business as usual, And so I want, especially folks with domestic violence, because there is evidence even internationally that individuals who are in those situations are now in some of a constricted movement situation. So they're with their batterer, if you will, and without a way to get some release or relief from that kind of pressure. So certainly we are here. We stand ready to help, and we'll do it with the exact same level of compassion and care.
there was a interview on the radio as I was going home yesterday, and a person was talking a little bit about that, and they said that before I could move away from my unhappiness, and now I'm chained to my unhappiness.
That's pretty.
And I think that is a real, it is, and it is a real concern. But I know you all and your team are ready to help. The SANE program you mentioned, talk a little bit about that.
So SANE stands for a Sexual Assault Nurse Examiner, and it has been, it's about, I guess 15, 20 years old now as a concept that says that, when an assault happens, a sexual assault happens, that we use designated individuals to do an exam and collect forensic information, and in the exact same way every time. It is not that emergency medicine physicians are not able to do those exams, but we've been able to establish that when it is done kind of the same way every time, almost according to a script, and that folks agree with that script throughout the country, that leads to a better rate from the legal standpoint for prosecutorial interventions. And so we also find that it gives the person a bit more sensitivity at such a trying and devastating time. So we've had that program here at KU for probably at least a dozen years.
Yeah, it's a really good program.
Yeah.
Other questions? Dave, I do think this thing about economic disparity is making a significant difference. You were talking a moment ago about the rise in case numbers in Wyandotte and Johnson County and how they're coming closer together. And again, just to say, Senator Moran will be with us tomorrow to talk about some of the economic relief packages and the economic health of our country and our community and the state. But the concerns about Wyandotte County and the rise are really concerning.
So, Steve, earlier you mentioned, I heard it on the news yesterday, and it seems to be a fact that Johnson County will start doing some of this testing of random individuals. So getting out in the population and just seeing on a random basis who might be infected. And I'm not an epidemiologist, but I do know that gives a sense of, without any pre-selection, who might have the infection. I haven't heard if Wyandotte County plans the same thing. Wyandotte County and Johnson County differ a fair degree in terms of economics. So median income is about half of what it is in Wyandotte County as Johnson County. Home ownership and demographics are different too. African American and people of Hispanic background make up probably 45% of Wyandotte County, and they make up a lot less of Johnson County. So I think if we're talking about how do we look at if there's a disparity, what the of that disparity is, Johnson versus Wyandotte, so to speak, could be a very interesting look at things. And I think that as this larger discussion continues to present itself about how COVID shows the underlying cracks in both the healthcare system and our social determinants of health, housing inequality, all other kinds of inequality, racism, all of that stuff will be something that we can look at with the aim of trying to be more equitable for all of our citizens, to value everyone equally and make everyone's health the best that it can be. Because in the end, we're all human beings, and we share tons more than there's any, superficial pigment differences among us. I mean, the problems that have affected people who have been disenfranchised are because of the elements and the tools of disenfranchisement. It's not because of something in their DNA. I think, as they say, may you live in interesting times, and these continue to be interesting times from a health perspective, but I think also from the perspective of, can we use every opportunity to do a little bit better, things he was talking
nicely
about.
Said. And as it moves into rural areas, especially Kansas, issues about economic concerns and healthcare concerns, insurance concerns are all magnified in a rural environment as well as in an urban and an underserved environment. So, man, we just have to have a good heart as we do this, because a good heart helps us take care of everybody. I think we have time for one or two more questions, and then we'll probably wrap up. Anybody else out there with a concern? Question?
I have a viewer submitted question, just real quick. I have a woman who has a feeding tube that comes out quite often, and I think this might just be a good thing to know, that if you need to go to the emergency room Can you still go? And this woman wants to know if she can still go to the ER if she
Is it still safe? Absolutely, Dave.
Absolutely. So, as I said before, and I truly mean this with every bit of candor, our specialty is actually built on we'll see anybody, anytime, 24/7, 365. I mean, that's who we actually are. So, feeding to chest pain, headache, thoughts that you might be having a heart attack, we definitely stand ready to do that. I mean, it's we're staffed for it. Our model has always been that we can flex up, we can flex down. I happen to presently work in a health system that has been fantastic. I don't think our providers, our nurse practitioner partners, our physicians, our residents are overly stressed with not having enough staff. I think we really try and have the numbers to address almost any situation. And I suspect as this particular challenge goes on, but I think that we've got, once again, the kind of backing and the kind of fortitude that'll allow us to do it. So certainly, like I said, if you've got a health concern, COVID doesn't eliminate that. I would say I respect the public for what appears to me to a move to say, if I really don't need to be in the emergency department, maybe I should wait, or maybe I should try and use our telemedicine capabilities to access my physician. So that's all very much appreciated, but I would not, and I repeat, NOT, not want any individual in our community who feels like they have an emergency not to come to the emergency department. It's who we are. It's what we do. What you don't want to do
is be sick and getting sicker because you're afraid of COVID.
Absolutely.
Yeah, that's not a good answer.
That is absolutely fine.
But I think we want to take care of you.
Yeah.
As we wrap up today, Dana, any thoughts?
It's a good question about drugs, therapeutics, treatments for COVID. We have to remember there are no drugs that are approved for treatment of COVID. We here at the health system are continually monitoring and changing our paradigms for treatment of and trials of medications. In fact, the CDC even issued guidance yesterday on changing there. And that's because a lot of this data that is coming out, it's inaccurate. We hope to get better and more accurate data. Right now, there is no treatment, so the best thing we can do is not get the disease. The best way to not get the disease is stay at home, shelter in place, wash your hands, don't touch your face. I know it's going to be hard with the holiday coming up, but please, as individuals, do the best you can to not be in those situations.
Any last thoughts as we wrap up?
I would echo Dana's points. Certainly, I'm an extrovert. I love to be outside, etc. But you really have to do the absolute best you can to follow all of these recommendations. I am somebody who, my script is to walk into a patient's room and reach out and shake their hand. I've been doing it for 25 years, but everybody has to make a change and an adjustment in how we act. Secondly, we stand here. The emergency department is fully open, ready. If you have a health concern, we're here to help it. Quick shout out to my colleagues in the emergency department, nurses, nurse practitioners, certainly our residents who bear a ton of work we do, and the marvelous faculty I work with. I think keep innovating and keep the spirit that you guys continue to have that continues to inspire me as I continue the journey in emergency medicine. So it's been a pleasure to be here, Steve.
25 years? Dude, I've known you longer than that.
Not quite. Well, yeah, Steve's actually, he's counting residency and intern. I used to have to follow him around.
That he is now. Thank you all for being a part of our session this morning. Remember, as we celebrate tonight and other holidays that are coming, the way you thrive and stay alive is to remember that there's no place like home. It's like home. Thank you all very much. We'll see you tomorrow.